Better quality of life and reduced fecal incontinence in rectal cancer patients with a watch and wait follow-up strategy. Gastroenterology Hospital, Dr. Carlos Marino, Buenos Aires City, Argentina. Colorectal cancer is a disease of great epidemiological magnitude. Its incidence rate shows an upward trend in recent years. In Argentina, it occupies the third place for both sexes. Rectal cancer represents approximately one-third of colorectal cancer cases. Anterior resection with total excision of the mesorectum is a surgery of choice when the sphincteric apparatus can be preserved, but it is associated with a series of pathophysiological alterations known as anterior resection syndrome, LARS, which affects 65% of the operated patients. The anterior resection syndrome combines to different extent and intensity disorders of the anorectal function, such as defecatory urgency, tenesmus, sensation of incomplete evacuation, fragmented defecation, increased number of bowel movements, and fecal incontinence, being fragmented defecation the most frequent symptoms. All these generate physical and social consequences that influence the quality of life of the patients who suffer. The condition may improve several months after surgery, and in more than half of patients, the symptoms persist 1 year after the surgical procedure. There are different pathophysiological factors involved. The following stand out: the decrease or loss of the rectal reservoir of compliance, damage to the afferent and afferent nerve pathways of the epigastric plexus with decreased anorectal sensitivity, and incoordination of local regional reflexes. Sphincter damage. The risk factors for developing LARS are radiotherapy, distance of the tumor to the anal margin, low anastomosis being the most at risk, technique of anastomosis and resection, end-to-end anastomosis presents a higher risk, lack of protective oxygen, age, the younger the patient, the higher the risk. Not only does surgery affect the defecatory and genitourinary function of patients undergoing treatment for rectal cancer, irradiation of the pelvis is also an important factor and tends to result in worse functional outcomes. Radiotherapy produces damage by two mechanisms: immediate, caused by DNA damage and capital brain, causing immediate cell death, or indirect as a consequence of free radical information. Link related to the appearance of an inflammatory and fibrogenic response in the irradiated tissue with progressive changes in the vascular and connective tissue. The intestinal mucosa is a tissue with a rapid response to radiation due to a high cellular turnover. It produces mucosal and pelvic nerve inflammation and manifests with the tenesmus, diarrhea, mucorrhea, and proctorrhea. Symptoms may appear during a few days after radiation therapy or months or years after the end of the treatment. The watch and wait strategy is an alternative to anterior resection in patients with rectal cancer that have had a complete clinical response to immunojavelin treatment. Few reports describe the quality of life and functional anorectal disorders in that population. The aim of this study is to analyze and compare the function of anorectal disorders and quality of life in patients with locally advanced adenocarcinoma of the rectum treated with neoadjuvant therapy, divided into two different groups: Group 1, G1, watch and wait, and Group 2, G2, anterior resection. Patients with a diagnosis of adenocarcinoma of the rectum up to 15 centimeters from the anal margin, non-metastatic, with a minimum post-neoadjuvant therapy interval of 12 months, with no evidence of disease, were prospectively selected after neoadjuvant treatment or watch and wait strategy, Group 1, or surgery with more than 12 months after the closure of the protective ileostomy, Group 2, in a single institution between January 1, 2013 and April 3, 2018. Exclusion criteria: local resection, previous pelvic radiotherapy, anorectal disorders prior to the diagnosis of rectal cancer, Complications of anterior resection, stenosis, dehiscencies of the anastomosis. It is an observational prospective cross-sectional study. All patients included underwent clinical history and 21-day bowel diary looking for information about number of bowel movements daily, number of fecal leaks per day, presence of defecation urgency and tenuousness, stool characteristics assessed using Bristol scale, sexual function, presence of erectile dysfunction and retrograde ejaculation in men and dyspareunia in women were questioned. Urinary disorders, the presence of urinary incontinence, urinary urgency, and tenuousness were evaluated. Fecal continence was evaluated with a modified Colby-Wexner anal continence scale that determines the severity of anal incontinence, considering whether the patient has leaks of solid stools, liquid stool, gases, sensoriality, reuse of fats, alteration in lifestyle. The score between 1 and 22 is okay. The severity of incontinence is classified as mild, 1 to 5 points, moderate, 6 to 10 points, serious, 11 to 15 points, and severe, 16 to 22 points. Each patient was given a fecal incontinence quality of life questionnaire, which is a specific instrument validated in Spanish that measures the quality of life in patients with fecal incontinence. It is made up of 39 items that assess 4 aspects: lifestyle, 10 items; behavior, 9 items; depression and self-esteem, 7 items; and shame, 3 items. Each item has a rate from 1 to 4. The higher the score obtained, the better quality of life. All patients included underwent conventional anorectal manometry. It is a technique that allows anorectal motor activity to be evaluated by simultaneously recording the pressure of the anal conduit and the rectal ampulla, both in resting conditions, and simulating physiological considerations. It was registered. The resting pressure that corresponds to the internal anal sphincter. Pressure with involuntary contraction corresponding to the external anal sphincter. Cough reflex. Push maneuver. Inhibitory rectal anal reflex. Rectal sensoriality. Ball expulsion test. Regarding results, 30 patients were finally included. 15 were men between an age of 62 years in the watch and wait group, and 57 in the group of operated patients. The median distance from the tumor to the anal line was 5 centimeters. Evaluating the 20 did not see any differences in any of the functional characteristics. The analysis of fecal incontinence evaluated with the Webster scale showed that even when it was still revealed in both groups, it was significantly less severe in group 1. The quality of life analyzed with the MIQL questionnaire turned out to be significantly worse in operated patients. Comparing the patients with fecal incontinence in both groups, a significant difference was observed with a lower score of those patients who had been operated. The anorectal manometric parameters did not show significant differences between the groups with any of the variables. These research conclusions are the following. The results suggest that a large percentage of patients treated with dental cancer, regardless of the strategy considered, present alterations in anorectal function and quality of life. The watch and wait follow-up strategy in patients with locally advanced rectal cancer was associated with better quality of life and less fecal incontinence. A greater number of patients are necessary to be able to confirm the obtained results in this study.